Okay, today we're going to talk about the cervical spine. First, we're going to do some review of anatomy. Generally speaking, let's talk about the whole vertebral column first. Obviously, it forms the central axis of the skeleton. It's right in the mid-sagittal plane, located in the posterior trunk. There are multiple functions. First, obviously, it provides support for your trunk and skull, provides muscle attachments, and actually protects the spinal cord. Okay, let's talk about how many bones are actually in your spine. Well, first, when you're first born, you have 33. Okay, so your sacrum and coccyx, your sacrum has 5, your coccyx has 3 to 4. Those end up fusing later, and you essentially end up with 24 true movable vertebrae. We have a little graphic here that shows kind of the shape of your vertebra as you go down. So we're looking from an anterior perspective here, and your cervical looks like the face of an elephant, your thoracic looks like the face of a giraffe, and then your lumbar looks like, let's call that an elk. Okay, pretty big. Now, they are divided into 5 groups. First, you have your cervical. 1 through 7 is cervical. Then you have your thoracic, which it makes up your back and the majority of where your ribs attach. You have 12 of those. Lumbar vertebra, you have 5. Sometimes you'll have 6, not too uncommon. Your sacral vertebra, you have 5 when you are born, and then you can see this is all fused together to make 1. And then your coccyx, 3 to 4 when you are born, fused to make 1. And so 33 when you're born, 26 when you are developed. Now, it has 4 curves in it that arch anteriorly and posteriorly from the mid-coronal plane. Sometimes this is confusing in how it is presented to you. And so if you think about it from the posterior perspective, it will make a lot more sense. Okay, so lordotic curves are convex anteriorly. Kyphotic curves are concave anteriorly. And so that's how you're going to see it referred to in your book. Now, let's look at that actually from the side when we're trying to identify it. So you have 4 curves essentially. So in your neck and in your lumbar, those are considered lumbar or lordotic curves. Okay, that region is considered lordotic. And then your thoracic and your pelvic curve, which is your sacrum and coccyx, are considered kyphotic curves. Okay, and then scoliosis is when you have a lateral curve. We'll talk about that a little bit more in a minute. And then if you have an increase in this kyphotic curve, that is considered kyphosis. And if you have an increase in this lumbar curve, then that is considered lordosis. Now, see how it says convex anteriorly. Okay, so that means on the front side it goes forward. Concave anteriorly means on the front side it goes backward. So it's make sure that you're understanding how it is being said to you. And if you can just relate it to the posterior portion, I mean, I relate it to the posterior portion, even though it's talking about anteriorly. So it's the opposite of what I would think, essentially. Hopefully you have a little bit better way to understand it than that. Now let's talk about scoliosis, and that is when you have an abnormal curvature from side to side. Kyphosis is the increased, again, in the T-spine. You have an increase in that concave anteriorly, and then lordosis is increase in the concavity posteriorly. And you can see that this is pretty significant. You can also see that you can see very well these joint spaces. So one of your clinical competencies is going to be a scoliosis. There are lots of incredible machines now that we use to do scoliosis, but you need to be able to delineate those images or those joint spaces so that they can measure what the curve is in your spine. So once you get to about 2, degrees, then you can get diagnosed. And then I don't think you typically have anything done until you get to about 10 degrees. I might just be making up those numbers. I don't think so. But it has to be pretty significant before they actually operate, but not too significant before you can be braced and some other things that they like to do. Okay, so let's talk again more about the vertebral column. So we have disc spaces, and then in those disc spaces we have little cushions, which we call those the disc. And so inside the little cushion is a soft centered mass, and then you have like a fibrous outside edge. And so you might hear the term H&P, which means that little soft mass in the center has herniated out. And so sometimes you'll hear that as a slip disc. And it does happen from improper body mechanics. And so that is why it is so important that you are protecting your back at all times. That's why we constantly are on you to raise up the table to make it working height, and to not lift with your back, but with your legs instead. And so there's other reasons to have herniated nucleus pulposus besides just improper body mechanics. But most importantly, it's the proper body mechanics. Okay, now let's talk about specifically the cervical vertebra. You have 7. Obviously, that is your neck. They have some unique features in them. So you have transverse foramina. So within your neck, in those foramina, because you'll have transverse processes on the rest of your spine, but they don't have foramina in the processes, okay? And so you're going to have arteries and veins that can pass through those, okay? They have a bifid tip, bifid meaning 2, like a double tip here on the spinous process. And then you'll see, and we'll look at a little bit more detailed of this. Obviously, this should be a review from anatomy. You are going to have to be able to identify these parts if asked. So make sure that you are reviewing those pieces. Now, I mentioned that typically this kind of looks like an elephant face. The cervical vertebrae kind of look like elephant face with big ears. I think it looks a little bit more like this. Okay, I can't remember the name of this fella from the Ice Age, but come on now. It could be a portrait. All right, so a little bit more specifics about your cervical vertebrae, specifically your first and second. They are atypical because they are used to connect your skull to your spine. And so you have C1 or the atlas and C2, which is the axis. C7 is also atypical because it joins with the thoracic spine. You might remember that C7 is your palpable landmark. Now, on C1, so this is number 1, you have an anterior arch, and then you have a posterior arch. You have 2 what we call lateral masses. So just kind of big, because there's no true body on this. And so these little pieces of more significant bone that you would probably have as a body on a different vertebra are called the lateral masses. Okay. The superior articular processes right here are going to receive the condyles of the occipital bone. So your skull is sitting on top of these little processes. And then these transverse processes are longer than any of the other cervical vertebrae. So, and again, that's for stability of your skull. Now, C2 is important because you have this little odontoid, and this is what we call the axis. This whole vertebra is called the axis because C1 fits right here on top, and then that's how your head turns from side to side. And so this slides up into C1. And then you have thick, broad lamina. The spinous processes are kind of horizontal in position. And specifically C1 and C2 require special imaging. Now, C7, again, we talked about already, vertebral prominence, because it has that long prominent spinous process. It should be easily palpable. It's right where your neck meets your shoulders, and it is the other irregular bone in the cervical spine. So, what unique anatomic feature is found in the typical cervical vertebra? Okay, so it says, so here's your question. So hopefully you can answer that without actually looking at the answers. Okay, absence of transverse process, no, they definitely have them. Absence of spinous process, we've got tiny ones on the majority of them. Presence of transverse foramina in transverse processes. There's your answer right there. Okay, so we have some arteries and vessels that pass through from your brain into your body through those transverse processes, and so that is the difference there. The dens is located on, okay, so that's the little odontoid. So when we say odontoid and dens, those are essentially the same thing, okay, and so we established that that is on, hopefully you are saying right now out loud, C2. Okay, so why do we do a cervical spine? Obviously, fractures is a huge one. You know, if you have an auto accident or any kind of an accident and paramedics respond, they're going to put you into a cervical collar and put you on a backboard. The cervical collar is what makes the cervical spine stable. The backboard is what makes your thoracic and your lumbar and your sacrum coccyx stable. Okay. So compression fractures, subluxation, which means your vertebra either go forward or backwards, HNP, which is that little soft space in the middle of the disc, intervertebral disc spaces that can pop out. So herniated nucleus pulposus, osteoarthritis, you can have stenosis in your spinal cord as well. So lots of reasons you're going to see these taken. There's, you know, we have spine centers everywhere where all you do is take x-rays all day, neck x-rays all day. But in the hospital, a lot of times if it's coming in on a backboard, it's going to CT anyway, but we are going to talk about some adaptations today. So we're going to talk about all of the things. So first, patient prep, our general patient position, the SID, because there are some variances within the cervical protocol. What is our collimation? Where do we put our markers? What kind of radiation protection are we using? And then what are our instructions to the patient going to be? So first, if you have anything from essentially the waist up, it's going to have to be removed. If you have a gentleman in just a t-shirt, if it's a regular thickness of a t-shirt, then you're going to leave that on. But earrings, necklaces, glasses, all of those things need to be removed. And if they can't be removed, then you need to notate that in your notes for the radiologist. Okay, so if they have an earring that can't come out, or but obviously the necklace, the bras, all those things need to come off. Make sure that you're securing it and returning it. Now, you're going to have ambulatory patients. They're going to come in post-op or pre-op or just because they have neck pain. And so those can be done either up or down. For non-ambulatory patients, again, we're going to do whatever we need to do to maximize the patient comfort. And then if we are doing a trauma patient, then we're going to move everything but the patient. So standard SID for cervical spine is 40 inches. Your book says 40 to 48 inches, I think. You're going to see 48 inches more and more in the hospital. Now, there are some differences in some of the projections. For instance, the lateral is going to be done at 72 inches, okay? And so if you do a lateral or you do a lateral flexion extension, 72 inches. The obliques of the C-spine can also be done at 72 inches. It just depends on the protocol of your facility, but the majority are considered 40 inches. So let's talk about this. How are we going to give the patient instructions? Obviously, we're going to explain and demonstrate the positions when possible. That means standing in front of the patient, not trying to stand in the place of the patient. Okay. Respiration is going to be suspended on most of the projections, but there are some exceptions. Hopefully at this point, some of these make perfect sense to you. For the lateral, we're going to expose after full expiration. Remember, and we haven't talked about this yet specifically, but for a spine, you're always going to include some of the next section of spine. So for C-spine, we need to see C-spine to T-spine. So you need at least a third of T1, okay? So the very first thoracic vertebra, we've got to be able to appreciate that the spine is in a specific line, which we'll talk about in lecture. For the open mouth, you're going to say, ah, so their mouth is going to be wide open. So this is another one of those awkward projections that we're going to explain to the patient why we're doing that. And we do that to actually put their tongue in the floor of their mouth. So that means they can't have anything in their mouth. So if they have dentures or removable dental wear, it needs to come out. If they have gum, it needs to come out. Okay. And then for the swimmer's technique, we can use a breathing technique to blur lung anatomy, which we've done for some other projections we've done before. But we're going to use expiration because you're going to use expiration more commonly than not. So let's look at a few of the landmarks that we can use to make sure that we're accurately positioned. So first, let's talk about the EAM. So if I have the EAM included on the image receptor, then I know that I have the very top of the cervical spine. Okay, so that's step one. It's back there. So if you look at where the mouth is in relationship to 1 and 2, that's why we're going to do an open mouth, because that is where it is. It's behind the open mouth, and so to get a good AP of that, we have to open it. Okay. C3 is about at the level of your gonian, which is the curve of your mandible right here. And then C4-5, on boys, it's super easy to see because it's at the level of the thyroid cartilage, so your Adam's apple right here. You're going to be able to see that pretty readily. And then down to C7-T1, that is at that palpable vertebral prominence, number 7, also right where the neck meets the shoulder, okay, or the neck meets the trunk, okay, not necessarily the shoulder, because you got big muscular fellows that the top of their shoulder is way up here, and then you have some people with not as good a posture, and that's way down here. And so we're looking at where essentially the neck meets the trunk of the body. All right. So now let's talk about what are the routine projections for the cervical spine. I worked at a facility that every single spine was 7 views. Okay, that's a lot of views of the spine. Typically, you're going to see 3 views, potentially 4 views. You might do 5 views. To comp on a C-spine, you have to do a minimum of 3, which is an AP open mouth, an AP axial, and a lateral. But depending on the protocol for your facility, it may vary, but those 3 are the minimum that you have to submit in order to get a competency. Now, we have to talk about several other projections that are not considered. Okay, I kind of have a misprint here. I'm not going to re-record the whole video, but I will. Your updated PowerPoint will have it when you get into class. And so non-essential is really the PA axial obliques. We do them more commonly AP axial, okay? And then the lateral hyperflexion, hyperextension, again, not considered an essential view. Depends if you're at a spine center and someone's having surgery, because obviously that is for range of motion. Okay, so let's start at the very top of the spine. So C1, C2. So this is a projection that you take 100% of the time. Now, if you are at a children's facility, you don't get the tip of your odontoid or your dens until you're, I think, about 6 years old. So you might not do it if you have a less than 6-year-old and you're x-raying a C-spine, but for everyone else, you're going to have to include that. Okay, so if the patient is supine, you can do this supine or upright. You are going to adjust the head so that you could, first of all, you're going to have to see the tips of their teeth, okay? And so you're going to adjust to find the tips of their teeth their mastoid process, which is the little bump right behind your ear, okay? And what you're doing is lining up the tips of the teeth, the mastoid process, and essentially the external occipital protuberance, okay, which is your inion, that little thing that's sticking in the back of your head. Now, do not put your hands without gloves on, or even with gloves, on this person's teeth, okay? I've seen people do that. It's not good. So you're going to open their mouth as wide as possible. The goal here is to make that line perpendicular to the image receptor. Your central ray, you see, is cutting right through the edge of the lips there, okay? So open their mouth as wide as possible. Someone will be running their mouth like me, and then as soon as you tell them to open their mouth, they act like they can't. Obviously, we're going to use our words here, and we're going to tell them what we're doing and why we're doing it. So, okay, I've got to take a picture of the top of your spine. This is a little awkward. It happens to be right behind your teeth, and so we're going to do some crazy stuff to make sure that we can see it. Okay, so use your words. Now, perpendicular center of the midpoint of the mouth, as I said, and then this is where the difference is, which is when you get ready to make the exposure, you're going to tell the patient to say, okay. We're going to talk about in the lab how to make sure that you're not walking all the way to the control panel and then saying, open your mouth, because what happens when you do that is that they reposition their head. Now, this is a recommended SID 30 inches. Our rooms happen to lock in at 40 inches, and so typically we're just going to shoot this at 40 inches. Check your protocols at your facilities to make sure that is still accurate for wherever you are. Okay, so here's what that's going to look like. And so what we're doing is we've lined up the bottom of the incisors with the bottom of the head, or the back of the head, the occipital bone, okay? Sorry, I didn't say that very well. What I'm looking for is this entire odontoid free of superimposition. I'm looking for equal and open joint spaces on both sides between C1 and C2, and then the lateral masses, which is essentially the thickest part of that C1 vertebra, okay? So no vertebral body in C1, as I mentioned before, but you do have lateral masses. And so, again, look how tight this collimation is too, okay? So you can leave it open a little bit more from side to side so that you can put your marker out here. But we're looking for lateral masses, joint spaces between C1 and C2 open, and the top of that odontoid free of superimposition, okay? Now, we have made the occlusal plane of the upper incisors and the base of the skull, you know, in the same plane. And we're going to talk about occlusal plane more specifically in just a few minutes. If the top of the teeth are over the dens, that means that your head is tilted down too much. If the back of the head is superimposing the dens, that means that your head is too far back. Okay, and so if you get all of these little lateral masses in that joint space free of superimposition, but you just don't happen to have the dens free of the top of the dens free of superimposition, there is a supplemental image that will help you, which is the Fuchs. And so we just add that on instead of just taking this picture again. Now, the shadow of the tongue should not be projected over the atlas and the axis. That's why we go, okay, and we push the tongue to the bottom. You want to make sure you have no rotation. So we're looking at the rami on each side as it relates to the middle of the dens. And then obviously you want to be able to see that bony trabecular pattern. You can see this person has some cavities that are filled in here. Now, if they don't have teeth, and or they have dentures and you tell them to remove their dentures, okay, and we'll talk about that in class, you're just going to have to visualize where you think those teeth would be in relationship to the base of the head. And again, we'll talk about that some in class as well. Okay, so this is a supplemental image if you don't get that dens free of superimposition, okay? So on this one, you are going to extend the head backwards. And so the tip of the chin should be, you should be able to run the line of your central ray down the mandible essentially and exit there. Okay. So just distal to the tip of the chin, perpendicular, again, good collimation. And this is what we're doing here is we're actually throwing the, here's the the foramen magnum, which is the base of your head. Okay, so we're moving the chin up, we're moving the base of the head down, and we're putting the dens into that little space. Now, why do you just not do this one instead of doing the open mouth? Well, because you don't see those spaces open. See how the C1, C2 interspaces are now closed, okay? And so you can't see the lateral masses kind of free of superimposition of, the base of the head also. So this is always a supplemental, and if you can't get the dens free of superimposition. It's also contraindicated if you think there is potentially a cervical fracture, but if you think about the position of the head, if they're in a collar, their head's already in that position. So you're not going to move their head if they're in a collar, but you could still shoot this projection. Okay, AP axial C-spine. Again, all of these can be done up or down. We're going to make shoulders equidistant to the IR or the board. This is obviously done upright, and so there's a range here of angulation of the beam, 15 to 20 degrees. Typically, if they are standing up, you're going to do the 20 degrees, and we'll talk about that in class. If they're laying down, you're going to do the 15 degrees. And so you're going to extend the chin and place the occlusal plane perpendicular to the tabletop. You're going to be centered at C4. And if you think back of where is C4, that is right at the Adam's apple. Okay, so remember that you are projecting upward. And so typically I go just a little bit under that and I can still get it. If you'll look at where the collimation light is, if I put my finger, I'm not going to put my finger in their little EAM, their ear hole, but if I put my finger up, I'm going to look for the shadow on the board. I don't need any light above that because there's no cervical spine above that, okay? And then mid-sagittal plane. All right, so let's talk about what is the occlusal plane. Well, technically the occlusal plane is from the back of the head through the level of the teeth, okay? Now, you can also see that if I redrew this line in line with the bottom of the jaw, that line is essentially the same, okay? And so you tilt the head up to get, so I tilt the head up to get the bottom of the jaw parallel to the floor. And what that does is also pulls this gonion out of your cervical spine, okay? Now for this AP axial, we're pulling this up so we can see 3 through T1 free of superimposition, but we have to get this jaw out of the way. Now, but when we're looking at the lateral, we're still extending the head back a little bit, and that's to get the gonion out of the cervical spine, okay? So C4, again, so if they're supine, we're going to give it less angle, and we'll talk about that again. So it enters slightly at or slightly inferior. So I like to go again just a little bit below. I think it gives you a better image. You're about 10 by 12 collimation. We'll talk about that some more in just a minute. And so what should you see perfectly? And that is the lower 5 cervical bodies, the inner pediculate spaces. And so that is the space between the pedicles. And then superimposed transverse and articular processes. Technically, your spinous processes, which you can see better on these lower ones, should be in the joint space right below the vertebral body. That says that you have angled it correctly, okay? Now, from the superior portion of C3 to T2 and surrounding soft tissue, so we want all the soft tissue, shadows of the mandible and the occiput, which is the occipital bone, are going to be superimposed over 1 and 2, so typically you can't see that. Remember that 7 attaches to T1, and T1 attaches to the first rib. So if you can find the first rib, okay, then you can count up from there to figure out which vertebra is which, okay? So this is T1, C7, C6, C5, C4, C3. and then 2 and 1 are superimposed. Okay, open joint spaces, again, by paying attention to the angulation there. And then evaluation criteria. The mid-sagittal plane of the head and neck perpendicular to the plane without tilt or rotation. The spinous processes equidistant to the pedicles. So again, spinous process, spinous process, spinous process. Here's the pedicle, 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 pedicle. Okay, the angles and the and are equidistant to the masseter processes. Okay, so that's what we're looking at up here, and then obviously bony trabecular pattern. Okay, now let's talk about the lateral C-spine, or the Grandy method. Now, this is when we go back to 72 inches. Okay, so 72 inches for this one. They can be seated, upright, standing. They can even be laying down, and you do it cross table, however you need to get it done. The top of the image receptor, okay, is about an inch above the EAM. Really, since we're using 14 by 17, I'm not really looking at the top of the image receptor. I'm looking at where the top of the light is. And so they have even more than they actually have to have, because remember, we have divergence. So I make sure that the light, the EAM, the external occipital or external auditory meatus, has light on it, and anything above that I don't need. But you can also see if he has glasses on, then his glasses is going to go right into C1, C2, so we don't want that to happen. So perfectly lateral. We know how to get someone lateral based on chest and everything else that we've done lateral. We want the mid-coronal plane perpendicular to the IR, mid-sagittal plane parallel to the IR. You're going to stand in front of this patient and look at their head and make sure that their head, neck, shoulders are straight, okay? And they need to relax their shoulders. And it says chin elevated and mandible protruded. You don't have to do some weird thing. Just make sure that the occlusal plane, which again we said was parallel with the bottom of the jaw, is parallel to the floor, okay? And then you know that the gonian is going to be out of C1 and C2. Okay, so now let's talk about horizontal ray, 72 inches. Again, we have a lot of OID happening, so we're going to increase that to, it says 60 to 72. Obviously, we're going to do 72. And then we're going to suspend respiration at the end of full expiration, okay? And so I show the patient that. I take a breath, and then I blow, and then I show my shoulders relaxing down. But again, look at their head at last before you walk away, so you make sure that they're straight. So what does that show? Okay, it's going to show all of the cervical bodies, okay, the articular pillars, and you're going to see your spinous processes, the lower 5 zygapophyseal joints. So the zygapophyseal joints you have on both sides of your vertebra, and they should be stacked. So you see right here, this 6-7 space, that's perfectly stacked, okay, stacked, stacked. Now you do have this kind of double effect happening, and so that's actually rotation in the spine. So you can have rotation and tilt on these, and so you got to be super careful. But I have all of C1 included. I can look at that little loop behind C1 to see if that's open. That means their head is tilted, okay? And then I should see, here's C7, T1, and so I should be able to appreciate that. I've put a little marker here because they haven't marked posteriorly. You know we hate that. We're going to mark anteriorly on everyone, and then they have lifted the chin up enough that the gonian of the mandible is not in C1 and C2. Obviously, I need all 7 cervical and at least a third of T1, C4 in the center of the radiograph, which is exactly where they have it here. And we talked about the neck being extended. And so then here's another little caveat. And so we already talked about if I can't see the tip of C2, the odontoid, on that open mouth, then I'm going to do a Fuchs. So I'm going to make that decision as a technologist. Okay, my next projection is a Fuchs. Same thing when we get down here to C7T1. If the top third of T1 is not on there, then we're going to have to take an additional projection for that C7T1 interspace. Okay, so you get to make that decision without asking anybody. So no rotation or tilt of the cervical spine. So we talked about this. So down here, this again is going to show us if we have rotation happening, okay, or tilt happening. This is a tiny bit of rotation. These being open would tell us tilt. Mandibular rami should be mostly superimposed. Spinous processes should be in profile. And then obviously we should have to see good trabecular pattern. Okay, so those three projections, the AP open mouth, the AP axial, and the lateral C-spine are the minimum requirement for your competencies in the hospital. Now, if you don't have all of the odontoid, which is again C2, then you're going to add the Fuchs, and that doesn't make it a repeat. That just means you've added the Fuchs. And if I don't have a third of T1, then I'm going to add the swimmers, and we're going to talk about that in a second. Now, there's other routine projections, which are obliques. Okay, so again, on the lateral C-spine, I'm looking for zygapophyseal joints. On the obliques of the C-spine, I'm going to be looking for intervertebral foramina. And so this little diagram is showing you where are those joint spaces in relationship to the mid-sagittal plane and the mid-coronal plane. Okay, and so the intervertebral foramina are going to be at 45 degrees from the body. That means you're going to, and they have them on both sides. So that means you'll do both obliques. Okay, but they're also 15 to 20 degrees. They open post or inferiorly 15 to 20 degrees. So in order to take an oblique projection, then you're going to rotate the body 45 degrees, and then you're going to angle the tube 15 to 20 degrees, depending if you're standing or sitting. Okay, so let's talk about the obliques. Again, if you have obliques ordered, that means you're going to do obliques of both sides, because these are where we're going to see the intervertebral foramina. So again, we can do these upright, we can do these supine. It's much easier to do them upright or seated than doing them on the table, but it can be done. Okay, and so you are going to rotate the body 45 degrees, and I'm going to give you some tricks on how to figure out what is 45 exactly. And you're going to be centered to the C3 body, and it says superior to the most prominent point of the thyroid cartilage. I always still center at C4, I'll be honest, and we're still good. And so typical logical order when you do these, because the AP open mouth and the Fuchs and the AP axial is done at 40 degrees, but the lateral is done at 72. And so the AP axial obliques, if I angle the tube for the AP axial, then the next two projections I'm going to do are the two obliques, and then after that I will move it all the way back to do the lateral, or I'll do the lateral first. Okay, and so 45 degree body rotation, 15 degree cephalic, and this is why I hate it when you guys take pictures, because it can be super deceptive. Okay, but it is saying they should be standing as upright as possible. So we are saying that's incorrect, so that's fine. So here's what I want you to see. I'm turning the body and the head. So the body and the head should be 45 degrees. You don't want to turn the body and then turn the head back. And I see technologists do this in the hospital, but that messes up what you're looking at here at the top. Okay, so head and shoulders are 45 degrees to you. And then I'm going to be at the level, it says C3 officially, but I still go about at the level of the C4. And if this is AP, if this mid-sagittal plane is AP, and then mid-coronal plane is lateral, then your CR is going to be landing right in the middle of that. Now we see this also if they are supine. Again, if they're supine, you're going to do just 15 degree angulation versus the 20 for up. I might have said that opposite a minute ago. If I did, I apologize. And just think about how the C-spine sets if you are standing versus if you are laying. And so it requires less angulation. So it says 60 to 72 SID is recommended to compensate for OID. And so even though I told you to shoot these at 40 degrees, if you're in the hospital and you can't, and you're upright and you can shoot them at 72, that's what I would do. But for our purposes, we can't get the tube low enough to do them at 72 on all the tables in the non-energized and the energized side. So that's why that we're going to do them at 40. Okay, I know y'all love it when I do things like that. All right, so what am I looking for? I'm looking for these beautiful little circles, and these little circles are called the intervertebral foramina. So on the apiaxial, which this is the essential projection, those are going to be the side away from the image receptor, and we'll talk about that in class, okay? So if I'm doing an LPO position, so my left posterior is touching the image receptor, then the right side is the one that I'm looking at, okay? And they should be uniform in size all the way up. Now, you can mark them both the same. You can mark them both left, and one of them you'll have the little circles on the right side. And so this is a LPO, and the right side is open, and then the opposite will be true for the next projection. You again want to make sure the mandible's not overlapping again, no occipital bone overlapping, those joint spaces open, and the foramina open, and the disc spaces are going to be open. Okay. Now, we are going to talk about the other projections, but first let's talk about adapting. Okay, so you're going to have people that come in on a backboard, and you need to adapt to them. And so anytime you're doing an adaptation, you're going to perform those as is. Let me repeat, we never adjust the C-collar or the head within the C-collar, even if it's in there all cattywampus and messed up, it's never adjusted. Now, you will see technologists adjust it, okay? You do not, as a student and also as a technologist, ever adjust the head or remove the collar. As a student, you never remove the collar. The nurse will remove the collar, or the nurse will obviously the doctor will tell the nurse, or the doctor will remove the collar, or the technologist will remove the collar. You will never remove the collar or adjust the head as a student, okay? So we can do 3 projections as is. One of them is the apiaxial. There's not any adjustments that we need to do, except for obviously if they're supine on the table, we're going to use 15 degrees instead of the 20 that we'd use if they were upright. But then for the lateral, we're going to do that in the C-collar, and we're doing all of these in the C-collar. And the swimmers we can also do in the collar. Now, I know we haven't talked about the swimmers yet, and we will just very shortly, but let's talk about this. So here we have, if they are in the collar on a board, you don't have to do this. But if they are in the collar and not on a board, you might do this. I still don't recommend doing this, obviously. But we're going to remember to center exactly the same. So if I'm doing cross table lateral, I have to remember that I'm still going to be at 72 inches. Okay, 72 inches. I'm still going to be centered mid-coronal plane, which is essentially level of the EAM. Okay, and then C4, which is the thyroid cartilage, okay, the Adam's apple there right in the front. Okay, so think about when we were doing chest x-rays and how we adapted to that. So it is gridded when we're upright, so it is gridded when we are supine. Okay, we call this a dorsal decubitus position because they are laying on their dorsal surface. Decubitus just means the x-ray tube is horizontal. Okay, and the patient is laying down. We're going to, again, relax the shoulders. Top of the image receptor, I'm not so worried about. What I'm worried about is just getting C4 and the mid-coronal plane in the same line. And then here you see kind of essentially what we're doing. So we're never going to get it centered exactly. We can do some things to try to do that. We're still going to do expiration. Okay, I'm going to put the marker. They have it, horizontal here, and that's great. that's fine. Just put it in light. Okay, your little BBs are going to tell the doctor that it is supine, and so I just put it here, but I usually swivel it if I'm being honest. Okay, so if again, the criteria for lateral C-spine is, do I have those zygapophyseal joints on there? Yes, I do. Do I have 1 through T1, C1? So 1, 2, 3, 4, 5, 6, 7, T1. I don't really see a third of the body. It gets kind of lost there. And so if I don't see it, that means I need to make my own determination that I'm going to do the swimmer's projection. Okay. And so it is considered a supplemental. It is a requirement when you're actually doing the thoracic spine. But again, if you don't see a third of T1, then that means I have to go in there and do. And so again, we do not diagnose, but we do recognize. So I'm recognizing that T1 is not included at least a third. So that means I need to do a lateral swimmers. And so this is what a swimmers looks like. Obviously, there's some adjustments. I don't know why I have it here in this PowerPoint, but so C6, C6, C7, T1. So this is a clavicle. That is a clavicle. Usually that space lands right in between those two clavicles based on position. Now, we'll talk more about that in just a second, but the radiologist is looking for the front of these bodies to make sure that it has not subluxed forward. Okay. They also look at the back of the bodies to make sure it hasn't gone backwards either. Okay. If you cannot get C71, then you are required to do a swimmers, but the doctor will actually also order a CT potentially, because that is the most common place for fracture. Now, this is what you see more commonly in the hospital. Both of these are lateral, cervical, thoracic, or swimmer's technique positions. Okay, this is a book projection where it's showing that you include, typically it's C4 to T4 on there. But what you see more commonly is you see all of the cervical spine. You're still centered where you're supposed to. It's still centered a little bit high here. But the radiologist likes to be able to count the spinous processes to figure out exactly where you are at where C7 and T1 is, even though they should be able to do it based on this. But you can see that there's definitely a difference. But I can appreciate the line here of where C7, T1 go. Okay. So here's that adaptation. And again, we haven't talked about the swimmers yet. I guess I threw it into the non-essential, but it is essential. So we'll adjust that again on the PowerPoint that you are presented in class, but it's just in a little bit different order here. And so this one we center at C7, T1 interspace. The reason it's called swimmer's technique is because it looks like you're swimming. So the side closest to the image receptor, that arm goes up, this arm goes down. The goal is for the movement of the shoulders. So that outside arm, the shoulder should go down, this shoulder should go up. You have to maintain that the patient is straight still. Okay. This can be done again on expiration, but you can also do a breathing technique. So what is the film size here? So if we're talking about the open mouth or the Fuchs, it's about 5 by 5. Again, you don't need light to go past, light should be up to the bottom of the nose, okay? Central ray should go through the middle of the mouth. So it's a small, but you can open it wider just to include the marker, okay? So apiaxial, at least 1 inch beyond the skin shadow. Typically, you start at a 10 by 12, 12 being the long axis with the spine. You can come in a little bit, make sure you use room for your marker. Same thing for the lateral, which is flexion, extension, and then swimmers and the obliques. We're going to be at about a 10 by 12, and sometimes we will adjust technique based on patient's thickness or their height. Okay. All right, so let's talk about the PA axial obliques. Again, we're just going to kind of breeze through these. These are the ones that are not most commonly done, although it makes sense for them to be more commonly done because the intervertebral foramina of interest in these is the side closest to the image receptor, okay? And so same thing applies as it did when you did the apiaxial obliques, except for I'm turning them the opposite way, so that means I'm turning the angle the opposite way too. So I would angle caudal instead of cephalic, okay? So again, intervertebral foramina are at 45 degrees from the mid-sagittal plane, and they open inferiorly, okay? And so that means that I'm going to angle posteriorly on if I'm doing them PA oblique. All right. So same thing as we did before. We're still going to do as much SID as we're going to do it at 40, but you can, 60 to 72 is obviously better to compensate for the OID. And then the images should look exactly like they did if you were doing them the PA axial oblique. It's just you need to remember that if I switch them around, then that means I'm going to switch the angle around also, and it's going to be the side closest to the IR instead of the side farthest from the IR. Okay, so here's a little summary of the obliques and the lateral. So anytime you're looking at spine, you're looking at intervertebral foramina and you're looking at zygapophyseal joints. So you see we just did cervical spine, and so it is the only one that is different from the others. So the intervertebral foramina is what you see on the obliques, and it talks about side up versus side down, and then the zygapophyseals you see on the lateral, and then we haven't talked about T and C spine yet. T and L spine yet, but they are the opposite. Okay, I finally found where my swimmers stuff is. And so, again, this is supplemental. It's not considered part of the routine only if needed when you're looking at the cervical spine. And so if you can't see the top of T1, at least a third of T1, we're going to always do this. So again, I could be upright, I could be supine, mid-coronal plane should be perpendicular to the image receptor. Mid-sagittal plane should be parallel to the image receptor. The side against the image receptor, that arm is going up. Now, does it matter if you do left or right side for the swimmers or in for the lateral? Technically, it doesn't matter, okay, for the cervical spine, but typically you're going to do it left side against the board because it's the more standard procedure and the patient is facing you and you can see their face, okay? And so when I put that arm across and over their head, potentially their head is going to lean toward that side. So we got to check it. Just like when we were doing, transthoracic humerus and things like that, you saw that their head would go away. So when they put that arm up, this opposite shoulder should go down. If it doesn't, you can angle 3 to 5 degrees caudally to overcome that shoulder, not going down with this arm being elevated. Okay, now I'm centered at C7T1, so you can find the vertebral prominence, or you can just see where the neck attaches to the trunk of the body, and that's where your central ray is going to be. Okay, I'm at 10 by 12, so they're showing this also supine. So not only can we do it cross table supine, but we can also do it just them on their side supine. Okay, and so again, it's harder for them to get the shoulder out of the way when they're like this, and so we can angle 3 to 5 degrees caudally. And again, what does that look like? It looks like this. So I should see C6, C7, T1, and then I can see T2, T3, so I can draw a line here, okay, on the front side of the vertebral body and on the back side. Those should be lined up, okay. I have to make sure that my technique is adequate. This can be done again on expiration, or it can be done as a breathing technique. I say just do it on expiration. It's easier because this is a harder projection to hold. And then the humeral head should be minimally superimposed, okay? And I should be able to see vertebral or trabecular pattern happening. All right, let's talk about ID markers. Obviously, they need to be on every single image. It says avoid using. I'm going to say they are prohibited. We on lateral stuff, mark anteriorly. Okay, on obliques, you can mark the same side both times, because anytime you can see both sides of the spine, okay, the right side of the spine and the left side of the spine, it's okay to just mark whichever side correctly. Okay. And then radiation protection, obviously we're going to use good collimation, optimal technical factors, and we're going to use a half shield and make sure that we're turning it appropriately for every projection. All right, so now let's talk about some other supplemental ones. And we're going to kind of zip through these because I'm already recording at 55 minutes, and I hate to make a recording that is that long. But hyperflexion, hyperextension, obviously that's going to be looking for the range of motion, essentially. Okay, the absence of normal movement from trauma and or disease. And so when you're doing flexion, so that means your chin is going towards your chest, the spinous processes are elevated and widely separated. When you do extension, the spinous processes are depressed into close approximation. So you're never going to do this if we're looking for a cervical spine pathology. Or if you haven't ruled out a fracture yet. We're not going to do this in the lab, but you will see it occasionally in the hospital, and especially if you're at a spine clinic. The big one on this is, I noticed that this fella's eye, it's like those dolls from way back when. Like when they tip their head back, they close their eyes and then they sway. And so one of the big things I tell my patients is to keep your eyeballs open. Okay, and so you're still in a lateral projection, and now you just say, okay, I want you to tip your chin towards your chest as much as comfortably possible. Okay, that's for the flexion, obviously. And then the extension, I have the pictures opposite. I'm sorry about that, of the words, okay, because this is extension and that is flexion, okay. And so, and then again, as far back as possible, central ray, again, mid-coronal plane, perpendicular to C4. It does look funny once he tips his chin back because it doesn't look like he's on C4 anymore, but he still is. Notice my marker, it is anterior on both of those. And then you can see what happens here. And so you don't want to make, you want to make sure that they're actually moving their head, both those things, and they're not just trying to move their spine. Okay, but again, they have marked posteriorly. We want to mark anteriorly out here in front. Obviously, we're looking to it and make sure that it's all included. Okay, no rotation or tilt. So, and then spinous processes in profile. So again, I'm looking for, again, zygapophyseal joints. Those are open, open, open. Then you have kind of little doubling effect. So that means that they're tilted slightly at the top. That could just be normal pathology. Normal for them, or, if they have some whiplash, we'll talk about that in class also. Okay. Body of mandible, again, you want to make sure that it's not in the C-spine. So you're still kind of pulling that forward just a little bit. Okay. So that is flexion, extension, which is considered a non-essential. The PA axial is considered not the routine in a hospital. It is the AP axials that we typically do. And so hopefully that is helpful.